Good evening, one and all. Dear Facebook Pure Urology viewers, as you all know, we are doing surgical technique based presentations every other day, focusing only on surgical technique based. Uh, Today topic is ECIRS, endoscopic combined intrarenal surgery. As you all know, the stone management has changed in the last 2 decades a lot. The primary reason being we are not seeing large staghorn stones now. We are seeing multiple stones in different calyces. We are seeing one large stone and two small stones, bilateral stones. Metabolic part of these stone topics are increasing. That's why people are looking for minimally invasive procedures. One among them is RIRS. In the last 2 decades, from 1990 when Grasso has invented tried RIRS way back in 1990 from USA, now it is so much popularized that majority of the countries are using flexible ureteroscopy and laser and trying to remove up to 2 centimeter stones with reasonably good stone free rate. But that's not the end. The prone PCL has been there for last 30 years because most of the teachers, most of the students followed the same and it continued. But after the RIRS has picked up, suddenly the supine PCL has come into picture because you can combine both. You can go through the flexible scope. If you have large load of stone, you can do supine PCL in the same position without changing anything. Primary position for RIRS, primary position for the supine PCL can be the same. That is in endoscopic combined intrarenal surgery. It may be in other way also, prone, simultaneous bilateral endoscopic surgery also. So to talk today, we have Professor Dr. Sung from South Korea and also his colleague Dr.Joonbeom Kwon from South Korea. Both of them are well-known urologists in South Korea. Before I introduce both the speakers today, I wanted to share personally, with the permission of the audience, that my daughter is interested in medical schooling and crazy fan of South Koreans because of their discipline, hard work, and of course some music. She will say hello to both the professors. I apologize for this interruption for 1 minute.
안녕하세요. Good evening, Dr. Chon and Dr. Kwon.
안녕하세요.
I'm a very big fan of South Koreans because they're so hardworking and dedicated. And BTS is one of my favorite groups. So that's how I developed interest in South Korea. Thank you. I thank my dad to give this opportunity to get introduced. Thank you. I hope this program helps everyone. Thanks.
Yeah, I hope to meet you in person in the near future.
감사합니다.
She's able to speak some of the Korean language a little bit. I hope you understood that. I did not understood. So with this, I will share my screen to introduce both the speakers. This is the today's topic, endoscopic combined intrarenal surgery, combined approach for renal stone. Professor Sung Yong is Associate Professor, Head of Stone Endourology Center at the Seoul National University Hospital, Korea. He is graduated from Seoul National University in Korea as a surgical urologist who specialized in diagnosing and treating people with urolithiasis, benign prostatic hyperplasia, stricture, and upper tract urothelial carcinoma. He is in charge of specialized endoluminal endourology stone center and usability test center in Symmetry SNUH Innovative Medical Technology Research Institute in the SNUH Seoul National University Hospital. He is one of the members who are leader stone surgery in Korea and East Asia. I'm fortunate to have him as speaker. He is the Korean representative of the Asian Guidelines of Urolithiasis panels in 2019 and has successfully fulfilled many educational works and live surgeries in the urological conferences. Our next speaker, his colleague is Dr. Joonbeom Kwon. He is the chairman of Department of Urology at Daegu Fatima Hospital, South Korea. Graduated from Kwangupuk National University Hospital, University School of Medicine, South Korea. Worked as an instructor at Kwangupuk National University Hospital. Specialized in endourology, stone surgery, and BPH incontinence surgeries since 2008. Member of Korean Society of Endourology and Robotics. He has published 27 papers. With this introduction, I will first hand over the program to Dr. Joonbeom Kwon initially. Over to you, both of you. In between, we will ask the questions with your permission so that it will be more interactive. And already, Gabriel Valdivia sir is online from Spain, and Hoonju Lee is also online, and Hang Joon Kim is already on the line. So total audience are around 50 audience are there. They will be joining. So let's have a good program today. Over to you. Thank you once again. Over to Kwon.
Thank you for introducing me. So I'm starting my speech. Do you see my presentation?
Yes, you are audible, visible.
Yeah, thank you. Hello, Chairman, and hello, everybody. It is a great honor for me to be invited as a speaker in this great conference. In fact, though I have an experience for 15 years about endourologic stone surgeries, I don't have lots of experience of ECIRS because of some hurdles to begin this technique. I will share this hardness later part of my presentation. A while ago, I met ECIRS cases from some of my colleagues. I learned some tips and know-how to overcome some hurdles to begin ECIRS. In addition, I have struggled with a poor stone-free rate in my patient with complicated renal stones using my preferred stone practices. However, I found some answer in ECIRS. Although I am not expert in ECIRS technique, but I think it will be better if I could share my experience about how to begin ECIRS and advantages of that. So today's topic is why and how do I decide to begin ECIRS in complicated stone. This picture represents the development of PNL. According to the development of instruments, PNL technique shows the real innovation for these 2 decades. ECIRS technique may be introduced in 2008 first. Before presenting my slides, I would like to introduce my preferred stone practices. As you know, it does not entirely match the standard guidelines. It just reflects my personal preference and experience, and some of them follow standard guidelines. I think every surgeon has his own practice based on his experience. It did not entirely follow the guideline, I think. When I met renal stone greater than 2 centimeters, I prefer PNL more than RIRS. I like prone PNL, particularly mini perk. I began it 5 years ago first. It has a great advantages in perioperative bleeding and hospital stay. Since I used mini PNL, I don't have performed standard PNL till now. I have escaped from the fear of post-operative transfusion and post-operative intervention for bleeding control. Even when I treat stagnant calculi, I use mini perk now. When multi-track puncture is necessary, I do not like 3 or more tracks. I know that even multi-track may be not seriously harmful in such cases like ultra mini PNL, but I want less invasiveness, though I need multi-track PNL. So in this concept, ECIRS will be ideal for me. I usually perform tubeless technique, but use ureter stent for facilitation of a spontaneous passage for remained stone fragments post-operatively. So in case of simple renal stones, it can be easily removed by PNL monotherapy or intrarenal surgery monotherapy. But how about complex stones? You may need for upgraded techniques in managing complicated stones. Stones with a large burden or stagnant calculi or stones located with very complicated renal anatomy will be need novel technique alternative to single-tract PNL or RIRS because it has a limitation for approaching and for stone freeing. For overcoming the result of single-tract PNL, I prepare one of belows. First, multi-track PNL. Second, PNL using flexible scope. Third, PNL combined with RIRS. So it means that ECIRS can also be applicable. However, I usually perform first and second method due to my convenience. In this complicated case, large burdened stone was, let's see the case. Large stone burdened are scattered in the different calyxes. So the dilated upper calyxes and mid calyx and the splitted and branched lower calyxes. Upper calyx, mid, and the lower calyxes. So when I planned this surgery, I would like to puncture with a double tract, one tract for upper calyx, the other through the lower calyx. But usually in Korea, PCM puncture is performed generally by interventional radiologists, particularly in my hospital. He told that he tried to puncture through the lower calyx, but the stone was impacted. So he placed the second PCM in the middle calyx, as you see, not through the lower calyx. So after treating the upper calyx, so I need to treat middle calyx and the lower calyx, but the second tract was placed to the middle calyx. So it is difficult to approaching the lower calyx, as you see. So after treating the upper and middle portion, I try to the lower calyx using the flexible scope, but because the middle and the lower calyx are neighboring, so the deflection is difficult. So I'm not completely approaching the whole entire lower calyxes. So unfortunately, there are some stone fragmented after the surgery. The middle portion is ureter stent. So if I have to treat this case again, I will plan ECIRS for this because it will have a more benefit to access. I will conduct intrarenal surgery first. So like with retrograde approach to the lower calyx and try to remove the stone first for making some places for the PNL approach. Then I will insert the PNL tract and remove the remaining stone in the lower calyxes. Then I will try to fragment the mid and upper calyxes, not remove them all, just moving to the renal pelvis or to the lower calyxes. And then I can easily remove the stone fragment through the PNL tract. The limitation of a multi-track PNL, which I feel is as below, it may make more injury and bleeding than single track. But in case of a mini-perk, the difference may be minimal. Also using multi-track, it still cannot approach to some complicated calyces. Like these cases, the stones are scattered and the calyx anatomy is very complicated. So multi-track PNL may not have advantages in such cases. I tried RIRS alone, but it was not enough. because the stone burden was too big. Stone fragment need to be removed spontaneously or through the combined PNL if I perform the combined PNL. But in that surgery, I did not perform the combined PNL. Particularly in this case, infundibulopelvic pelvic angle is very acute. So lots of fragment after surgery were still remained. If I conducted this combined with the PNL, it would have given better result.
Yeah.
Like this case, yeah, see the image first. Yeah, some of small fragments are located in the upper calyx, and the multiple stone fragments are with pelvis and the lower calyxes. So I tried to PNL through the lower calyx, and I removed the lower calyxal stone and the renal pelvis stone. But some of the stone fragments are moved to the upper calyx during the surgery. But using the rigid scope, I cannot approaching the upper calyx. So I using the flexible scope to the upper calyx, and luckily I can remove all of them.
Yeah.
But this technique also has some limitation. It is hard to access nearby calyces. So see the video clip. So this is a multi-track PNL. This track is placed to the upper calyx, and the second track, yeah, is to the mid calyx, and through the mid calyx. Oh, no, sorry, this is an upper calyx approach, and I try to the lower calyx approach. The angle is acute, so it is difficult to approaching the lower calyx. Yeah, see this. Oh, sorry. You see this?
Yeah.
Yeah, the UPJ and yeah, mid calyx is here.
Yes.
But because of the angle, the deflection is difficult. So I cannot approach the lower calyx completely.
Yes.
So like that, the neighboring calyxes is difficult using the flexible scope, even though you're using the PCN tract. So how about ECIRS? If assessed from the ureter, most calyx may be accessible combined with the PNL tract. So no more need for multi-track PNL. Because of this, stone-free rate will be better. But like usual RIRS, ECIRS also be affected by ureteral anatomy. For example, long segment ureteral stricture in rare cases. When I set up the ECIRS, I met some hurdles. Modified supine position is unfamiliar for PNL and me. Particularly, this steel bar besides the surgical bed interferes the fluoroscopic view. In addition, some instrument for supporting the hip restrict the motion of laparoscopy. So like in this time, I'm using the supporting tool in the shoulder, but in the past, I'm using this supporting instrument to the hip side here. So when I want to the motion of the endoscope, it greatly inhibited by the supporting tool. So now I do not set up here to like this instrument. It is very important point. Yeah, you can see the left position. It may be great for the endoscopic working. There is no interruption for endoscopic movement. For steel bar, here, red side, steel bar may interfere the fluoroscopic view. In the right side position, fluoroscopy was relatively free for interruption. Yeah, but the table protruding to you may restrict your endoscopic movement. So you need to elevate patient bottom from the table. So like this. In this patient, he was supported by some kind of very soft material, and his bottom is somewhat upward from the table. So the table cannot interrupt your motion. But in this position, the table is very protruding toward you. So sometimes you want to the upper endoscopic movement to the upward position. So the outside of endoscope can be inhibited by the table. So it is important. So if you use some material to elevate patient bottom from the table, it will be helpful for your endoscopic movement. This is the same explanation. So the table is somewhat not protruding, so your endoscopic movement is free. So it is very important. For most PNL in Korea, PCN guide wire was placed before surgery, with the prone position by radiologist. So when patient is positioned with modified supine, I met the situation PCN guide wire is torted and curved, not straight. This happens due to nephrotosis or hypermobility of kidney in supine position. It is hard to perform PNL in this state itself. You need to pull both sides of guide wire like right picture. So in this side and this side simultaneously. For straightening of the tract, the right side fluoroscope, then you can make PNL tract. It will be safe. But if you are going to try PCM puncture in operating room, it may be difficult to PCM puncture due to mobilization and unfixed of kidney position. So it will be helpful using flexible URS first. Under direct vision of a PCM puncture site, you can insert PCM under the guidance of sono. So you see this video clip. So after the retrograde intrarenal surgery, and you can see direct vision, the puncture of the PCM needle and guide wire. I think it is very effective and relatively safe.
Yeah.
So I will introduce some of ECIRS case. The first case, see the picture. This patient has a half stagon, so usually located in the upper calyx. Some of the stone fragments are located in the middle calyx. This and this. So the patient want a less invasive technique. So first surgery, I tried to RIRS.
Yes,
This is usual surgery video. But in the anatomy, the infundibular pelvic was very acute. So unfortunately, after the surgery, when I follow up, most of stone fragments are scattered in the middle calyx and lower calyx. Because the infundibular pelvic was very acute, most of stone fragments are not passed spontaneously. So when I planned the second surgery, I was very considered, and I would like to conduct ECIRS because of first, for removing middle calyx stone, and the second reason, RIRS alone may be hard to remove fragmented multiple stones scattered in lower calyxes. Luckily, I can remove all of them. This is the second case. Kindly, this case was donated by Dr. Kwon in Hallym University Gangnam Hospital. You can see the right side kidney. The stone were located, the stagon stone are placed the lower pelvis, mid calyx, and some of them are upper calyx. Like this. So yeah, position was modified supine position. He also using the support material. I think the bottom of the patient is somewhat upward from the table, so he can gain the good space for the surgical working. The tract was punctured to the lower calyx, and see this video clip. So perform the mini perk first. This is metal dilatator. The outer sheath is 16 French.
You use sequential metal dilators?
After the fascial dilatator, so for me, I using the fascial dilatator like 10 French and 12 French and directly to 16 French. But maybe he directly puncture after the fascial dilatation when I see this surgery. This is outer sheath, 16th French.
Actually, I think the product is the one-step dilator from Carstens.
Yeah.
This is a first track, and he find the true track. Yeah, in the correcting system, and this is stone.
Yeah.
Yeah. After the fragment, the lower character stone and the renal pelvis stone. So
you use laser most of the time?
yes, this is a ureteroscopic view. So
yeah.
retrograde advance of a flexible scope to the kidney level, and he approaching to the upper calyx.
Yes.
For removing the upper calyx stone. Yeah, you can see this flexible scope to upper portion.
Yes.
Yeah. So this is stone using the basket. So he trapped, and so try to remove this stone to the renal pelvis. Sometimes the infundibular stenosis, this kind of stone lead to fragmented, small, but this patient didn't have infundibular stenosis. So this big stone easily can move to the renal pelvis.
Yeah.
And then removed outside of the body. So good. So this is conclusion. So I know that there are no comparative study about the ECIRS and other complicated combined technique like a multiple track PNL or PNL using with a flexible nephroskop. But for my experience and the other person, so I can conclude this. For treating the complicated stone with large burden and complicated renal anatomy, ECIRS may have a better access than multi-track PNL or PNL using flexible scope. ECIRS may have a more benefit because it is less invasive and more efficient in stone removal compared to multi-track PNL or PNL using flexible scope. PCM puncture may be hard due to hypermobility of kidney, particularly upper calyx in supine position. Operative field is restricted more than prone PNL. This depends on the good or poor positioning of a modified supine position. Not mentioned above, but I think distance between skin to kidney seems to be longer than prone PNL. I don't know, it is just my private thinking, but how about you? Thank you for attention. Thank you, everybody.
Thank you very much, Dr. Kwon. Dr. Gabriel Valdivieser has commented that in some cases, flushing with saline solution through a cobra catheter allows dislodging of some stones and reduce multiple tracts. This many of us do with a small needle placed in the other stone region, and then try to flush. Sometimes they come down, sometimes they don't come down, but RIRS definitely make it more objective, and we can take out all these stones and put it into the nephrostomy person. With this, we will go to the second speaker, Professor Sung Yong Cho, for his talk. Let us listen from him the other aspect of ECIRS. Over to you, Professor.
Okay, thank you for introducing me very well. And can you see my slides?
Yes, yes.
Okay, let's get it started. Good evening, ladies and gentlemen. Nice to meet you all today, and good to see you, my friend, especially Dr. Chandra. This is my great honor to have an opportunity of a presentation about combined intrarenal surgery. And today my topic is about a single main surgeon combined intrarenal surgery. And I think it's not quite academic one, but practical topic for us. So don't be too serious, and please enjoy my small talk today. And my take-home message is quite simple. I can tell you at least how the topics about mini PCNL and ECIRS started in Asia with my history. I'm working for the Seoul National University Hospital, and this is affiliated to the College of Medicine in Seoul National University, established in 1946. More than 210 board-certified urologists have been produced here until last year.
Yeah.
Faculties, I mean, in the training hospitals of Korea. And this hospital still has a role and responsibilities to bring up and educate the top-ranked doctors to become good investigators in the field of medicine. So although there are many hospitals where urologists can perform only a flexible ureteroscopic surgery, even the stones are large, I mean the staged operation, but my hospital and I feel that we have to show the standards of stone surgery with acceptable efficacy and safety. So we know urologists are trying to get enough devices to do this with limited resources, and it must need much time to achieve a certain level of quality. So I cannot forgive you performing the mini PCNL for big stones. And just we have to consider this the surgical outcomes regarding this. So we can first choose fewer complications, and we sometimes have to stop fragmentation and remove the scopes if there is much bleeding, even though we can leave some remnant stones in the kidney. At this time, the best results can be slightly different regarding patients' safety. So the stone-free rate is not the ultimate goal to achieve the good surgical qualities in this situation. So combined approaches may be the actions to improve surgical efficacy and safety together in some instances. I have to explain the terminology of ECIRS first, and the modified version of single surgeon combined intravenous surgery in the first place. Cesare Marco Schiaffone, many of you, I believe, many of you already know him. And he published an article about the simultaneous performance of PCNL and retrograde ureteroscopy, I mean the simultaneous approach, named ECIRS in 2008. And I love this concept very much, although the first concept of combined surgery didn't originate from him. But I value him very much because we know that a naming ceremony, naming thing can be helpful to disseminate it to other colleagues in some situations. And I have to add, I think I have to add single surgeon consecutive combined intravenous surgery when we consider the flow of the procedures in the operating room. To treat complicated urinary calculi, I usually plan what type of surgery would be the best option for my patients. For small and multiple stones, I do not hesitate to choose RIRS first. And for big stones, I consider miniaturized PCNL first and RIRS as the next option. However, when should we consider the bidirectional combined approach of antegrade and retrograde access? It may mean the initial bidirectional approach, I mean simultaneous to the target, or intraoperative conversion of the surgical methods chosen in the first place. So it is essential to the surgeon and more critical to our assistants than us. We have to prepare the surgical equipment and devices and the patient position before surgeons like us arrive at the operating room. The kidneys and the renal stones show many different complicated situations, including some examples in this slide. And Dr. Kwon already introduced some good cases for performing ECIRS, and so I'll briefly move on to the next slide. And this is another case of renal stone with ureteral stricture in my last year, and there was actually a renal pelvis, a big stone, and some additional fragments in the lower pole. And my resident performed double J indwelling 1 week prior to the main surgery, but the upper tip was located in the upper ureter and not in the pelvis. So the operative record was incomplete, written by a resident, and I couldn't guess the presence of upper ureteral stricture when the patients lie under general anesthesia in the operating room. So when I performed the RIRS first, the ureter kinking was not so good, and the final destination was just immediate conversion to the antegrade ultrasonic puncture with position change from lithotomy to modified supine position. So in the era of flexible scopes and miniaturization, so how to perform combined intrarenal surgery to maximize our surgical outcomes? I always think of this again and again. I mean, so the first thing to do is to choose the method of approach: antegrade first, retrograde first, or the simultaneous approach. Usually, the leading surgeons place their position on the PCNL side because the initial step of PCNL, I mean, especially puncture technique, is more complicated than those of RIRS. And certainly, it is a matter of experience of the two surgeons, and they can change their positions with each other if the main surgeon is more familiar with RIRS first. No, I mean the second surgeon is more familiar with the PCNL procedure. So we can choose an antegrade approach first, and it can fail in some situations as follows. I show some examples like this in this table: small movable kidney, prolonged puncture time with bleeding, narrow and steep calyx. I mean, there's no dilatation when there is much irrigation. Even when there is much irrigation, sometimes the calyx would not be dilated. And uretero-pelvic junction is, some urologists call this a uretero-pelvic junction or pelvo-ureteral junction obstruction. I mean, without an hydronephrosis or if we don't have any ultrasonographic device, and immediate bleeding when we make the puncture. And there can be some other situations as well. So we can choose a antegrade approach first, but we have to convert the surgery to the retrograde approach. And then we can choose the retrograde approach first, I mean the vice versa, and it can fail in these situations such as diverticular stone, lower pole calyx of the horseshoe stone, horseshoe kidney, separated calyxes, etc. And there are many steps to perform a combined intrarenal surgery. I show some examples here. one by one, and needle puncture by using ultrasonographic device or fluoroscopy as well. Insertion of a guide wire in with the access needle, insertion of balloon catheter or metallic dilator like the Dr. Kwon already showed, and through the guide wire to form the percutaneous tract. We can perform sometimes in some the ancillary procedure with a flexible nephroscope or ureteroscopy through the percutaneous tract or the ureter. Yeah, my preference is to use the ureter because Dr. Kwon already showed some difficult cases to approach to the lower or mid-pole callus using the percutaneous tract with a flexible nephroscope. And we already know the situation. We fully understand the situation. And because of the fragility of the flexible devices, second surgeon should be an expert if he or she wants to handle the flexible device. There are many tips and tricks. Even the leading surgeon wants to handle the flexible device through the percutaneous tract or the ureter. So we all know just all of these things are derived from the fragility of the flexible scope. So when the main surgeon want to put in the flexible ureteroscope or flexible nephroscope to any specific calyx, specific position, sometimes the second surgeon or the assistant should grab the percutaneous tract sheath, not to make some angle or just external damage of the external surface of the flexible scope. It's very important sometimes, right? So if the percutaneous tract is located in the mid-pole calyx, then the flexion of the flexible ureteroscopic to the ureter can make some external damage to the flexible scope. So the surgical can be successful at that time, but the next surgery would not be successful because of the absence of the flexible ureteroscopy with the external damage, external surface damage. So in many cases, the assistant can have some roles to facilitate this ancillary procedure like this. I already explained this situation. And when we consider simultaneous approach to the target, the second surgeon can perform a simple case of RIRS and cystolithal apoxy. And my residents also perform some simple case of RIRS and cystolithal apoxy, or sometimes transurethral surgery of a prostate. So while he does this, the leading surgeon, the main surgeon can perform PCNR smoothly without considering some difficult situations of my assistant or the second surgeon. Now I describe each step of the combined approach to a complicated renal stone. In the flank side, percutaneous puncture, insertion of disposable devices or metallic sheath, lithotripsy, and another puncture or flexible ancillary procedure if it is necessary. In the leg side of the patient, guide wire and ureteral catheter insertion, ureteral access sheath insertion, manual or dependent irrigation, RIRS or cystolithal apoxy, and RIRS in the contralateral side to the PCNO side. But when we consider the order of time of these steps, if the second surgeon is not an expert, if they are residents or fellows with little poor experience, we have to find the most efficient way of performing combined surgery. So red color text in this screen mean the procedures for an expert. And the rest of them, in black, they can be applied to an expert and a beginner together. So the time of lithotripsy is valuable to our residents or the fellows because they can sleep during this time. And it becomes sweeter when the stone is bigger because the lithotripsy time can be prolonged for 20 minutes or 30 minutes. So if the second, so they can sleep quite well. But if the second surgeon is an expert, we don't need to worry the conflicting of the time when the main surgeon does the another puncture or the ancillary procedure, and the second surgeon does the RIRS, cystolithorapaxy, BPH surgery, or the RIRS in the contralateral side. If the main surgeon is a beginner, what if, if the second surgeon is a beginner or a resident, the main surgeon has to move to the leg side after he or she finishes the main procedures in the flank side. So I calculate actually the loss of time. So, when the second surgeon is a beginner or a resident. This is the timetable. 10 minutes for puncture, sometimes 5 minutes or 15 times. Okay, it depends on the experience. And stone fragmentation time for about 20 minutes, and double-joint catheter or some ancillary procedure for 10 or 20 minutes on the contralateral side. If the main surgeon has to do it solely, then the surgical operative time can be shown like this. If the second surgeon is a resident and fellow, sometimes they don't have any rules. I already explained the lithotripsy time for siesta for them. And if the second surgeon is a skillful surgeon, we can save some time. But saving time can be just 20 minutes or around or so. And if you use some more devices, more technological things, then we can save more time to achieve the surgical outcome or ultimate goals of our stone surgery. So some urologists try to talk about the inefficiency of performing ECIRS with double number of devices. But actually, we don't need this because if the second surgeon is a resident or fellow, just the time saving is around just around the 20 minutes. And I think the two experts in the two operating rooms are better than the two experts in a single operating room. So just we have to weigh the value of between these two situations. So I think my take-home message is just quite simple, as I already told you from the beginning of this presentation. That is, two experts in two operating rooms are better than the two experts in a single operating room. So do not hesitate to train your residents and fellows actively, and please give more opportunities to experience directly the stone surgery with the main surgeon. And I think that just too high number of equipments or devices. We don't need to worry about this while we perform the combined intrarenal surgery. So just it is quite a simple small talk, and thank you for your listening.
Thank you very much, Sung, Professor Sung. That's very good talk. We have another 10 minutes time. I will share quickly my experience because this is also one of my heart surgery. I do a lot of ECIRS. Actually, during these presentations, I do not present, but because I am doing a lot of work and maybe it is useful for the continuation of this presentation. I really appreciate Dr. Kwon for telling the position, especially the rod which comes in the C-arm, and focusing on the thigh retraction, because if you want to puncture inferior calyx in ECIRS, it is sometimes difficult when obese patients and when the patient is not at the edge of the table, if it is not tilted with a bolster. That is a very good point taken, dear Kwon. And regarding a very important point told by Professor Sung is sometimes you don't require two monitors, you don't require two surgeons. You can go down and you can get this small stone into the pelvis, and then you can come back to the nephrostomy tract and then take it out. You need not have two experienced surgeons, what Professor Yong has mentioned. So it's all it's variable actually, depending on the RGP, depending on the stones, depending on the volume of the stone also. Larger volume, experienced surgeon first start PCNL. The smaller volume and small stones, bifid system, multiple complicated intrarenal calyces, yes, RIRS surgeon can do it. Meanwhile, if the bladder something is there, a junior can do it. Great message. So with this, I will share the screen, and I promise I will finish in less than 10 minutes about my talk, because when Professor Sung told that you also present, I made some slides. So there's a lot of literature now saying that the prone also they are trying. Thank you all the audience. I will quickly finish my talk. These are the various literature available about the now recently microendoscopic combined intrarenal surgery. I feel micro is less useful because large stone burden, again, it is a problem. Then simultaneous bilateral endoscopic surgery with washout mechanism, as Valdivia sir has mentioned. Then a case report where in split leg position prone also has been reported recently. And one more modified prone split position is also recently published by Dr. Wang et al. So I am sharing here the brief position of the patient in relation to this is the patient supine position, and the monitor is on the left. The ultrasound is on the left side of the patient, monitor on the right side. As you progress, I will show how the C-arm and everything is arranged. You can arrange two monitors on either side of the patient like this, and the C-arm will be always on the opposite side of the supine PCNL, whereas for RIRS, C-arm is not very important. Now, posterior axillary line should be drawn in the standing position before giving anesthesia. Otherwise, you will produce two lines which are much anterior, then it is dangerous. So posterior axillary line is posterior axillary line, which is when the arm is by the side. Now coming to the ultrasound, you can see so clearly the muscles of the abdomen and the kidney. Whenever you shift the probe from anterior to posterior, the entire kidney is free from the colon and the liver. These are the positions which we show here. See, this is the position, simple position. One small bolster at the below the shoulder blade, and one at the. Now this is exactly Kwon was telling. This is another just below the small one below the thigh. Enough. This position will take half-minute time, and you are assessed to URSL, RIRS, HOLEP, the supine PCNL, and also laparoscopy. This is what we do routinely when upper ureteric stone is not able to come out in either of the ways. The laparoscopy also can be done in this position. One position for all the stone surgery: URSL, RIRS, SBES, ECIRS, supine PCNL, and then laparoscopy. See, I am straightening the leg here. When you wanted to go to the lower calyx, we tilt more like this so that you can go to the paraspinal region. Now I will show briefly. See, this is the stone which we thought is very simple case, but when we did the RGP, it is true bifid system. You need minimum 2 punctures to remove the stones because you cannot enter from the lower pole to the upper pole. Large stone burden was there in the lower pole. Then puncture is done. 2 punctures are done for lower pole itself. I mean, middle part of the middle calyx of the lower pole also punctured. In fact, that was also a bifid system. Both are removed, and then at the end, upper pole one is taken out. You can see here how the flexible scope is coming 2 times to rescue, avoid the other track. I will quickly share the video. This is a picture. This is a position. This is a puncture. These stones are like this. We use pneumatic lithotripter for large stones, and then this is removed all. Now I am not able to turn, as Kwon told. We cannot go into the upper calyx, no chance. Otherwise, infundibulum will tear. The stone is partially visible. Now, what the flexible person is doing? This is the Dakota basket, which you make quick fragments. No need to make powder. Designer cut in the center of the stone. you can give and get it quickly to the nephrostomy person and take it out. Definitely stone-free rate will improve. This is one example. The another one is just above the amplage. Sometimes you may not able to get it, but here the flexible scope person is able to bring it out to the nephrostomy person. If not, lace it. If you cannot bring it out through the narrow infundibulum. Ultimately, this is a tract, and the lower calyceal stone, one more is there. This is the nephrostogram at the end. Another important case is multiple stones. This is a position. See, total 13 stones were there. We did not suspect PUJ, but this is a picture, trifid system. Here also it is very difficult to remove all these stones. So inferior calyceal safe puncture is done like this in supine PCNL. You went inside, you have seen all these stones and removed. This is a quick video. This is the position. This is the RGP, simple puncture. Now you are into 30 French because they look like secondary stones. Now the flexible scopy person is coming. You are not able to go with rigid scope into the upper trifid system. Now as shown by Kwon and Professor Sung, see now the flexible scope person will come and take the large stones easily. These are secondary stones. We in fact suspected PUJ, but post-op DTPA scan was normal. So see, these are the stones which are coming out through the nephrostomy tract with 30 French tract. So very quick surgery, nearly 13 stones are removed, and rewarding at the end, everything is collapsed, and these are the stones. These are the stones. They are secondary stones, but PUJ is not documented, and so we are wait and watching. This is a complicated, see, you can see like many of these cases are shown by Kwon. So intrarenal meaty kidney with this type of RGP, you cannot enter with flexible nephroscope also. Flexible nephroscope has disadvantage of amplage sheath hindering the movements of 15 centimeter nephroscope. In that case, only one puncture you can do properly. Rest of the things done by the flexible person. See, this is the puncture lower calyx, and this is a system get into the then dilatation, and this is the video, quick video. So I'm rolling fast. This is a partial stagger like thing, punctured. Now see the flexible scopy person is easily entering into all these stones. The compact system is very good for flexible scopy. This is the puncture. This is the stone removed by PCNL surgeon. See, this is the angle Dr. Kwon was mentioning. If you tilt the thigh, the buttocks a little more medially, it will be useful. See, I'm not entering anywhere now. Now I will go into the other calyces like this and bring it out with the basket, preferably this type of basket which can remove the stone easily. Now the flexible scope person is taking it out. So like this, we can show any number of the cases. See, at the end, no injury to any of the calyces except the inferior calyx. Last case is simultaneous bilateral endoscopic surgery in extension of ECIRS. Again here, this is the last video I am showing. So basically, you have a 65-year-old female patient who has breathlessness, who cannot come for the anesthesia, and see one side large stone, one side small stone, same position for all the procedures. First, you get access to the one side. This is for PCNL, very easy case. So anybody can puncture and do it. Other side, you put the access sheath. Now both are, first you puncture the kidney. Let the RIRS surgeon sleep, as Professor Sung said. And now once you punctured, once you are inside the system, now both are operating now. The RIRS surgeon junior and PCNL surgeon senior will be operating, one using pneumatic lithotripter, another using the RIRS. So ultimately, technology can be used safely, provided you have a urine culture sterile, you have a good drainage system, if you have ureter dilated well, and if you have an ideal case, both can be done in half an hour, and that saves time, that saves money, that saves 2 admissions, and patient safety also if the cardiorespiratory system is compromised. So I thank once again for giving this 10 minutes extra. Now let me have few questions from the audience to both of you, so that we will finish in another 5 minutes. By the time it will be 1 hour. My first question is, to Dr. Kwon. I feel it is difficult to go in prone PCNL from inferior calyx to superior calyx because it is more anterior. In supine PCNL, I feel very comfortable pushing the stone in the pelvis, in fact, into the upper calyx, so that supracostal punctures can be reduced in supine and ECIRS. Do you agree? And what is your take on one calyx to other calyx movement in supine PCNL, where you find easiness? I wanted to ask you where, in which situations you find very easy to go from one calyx to other calyx in supine PCNL.
I agree your comment. So in that cases, I usually use a flexible scope. Yeah.
Yeah. So you use flexible scope in such cases?
Yes. For the approaching the upper calyx, I usually using the flexible scope from the lower calyx approach.
Okay. Professor Sung, when you do PCNL, if you do RIRS, it looks little bloody and you need more saline to flush. However, good puncture is, normal RIRS is very clean, but post PCNL RIRS is little red vision and bloody. What do you?
Yeah, good point you raise, and it is a good question, I feel. And if there are multiple tracks to the kidney, even we increase the irrigation pressure to a very high level,
yes,
you can see no increase of intravenous pressure. So if we make 2 punctures to the, if we perform ECIRS,
yeah,
we can guarantee 2 tracks of a percutaneous and retrograde approach if we use ureteral access sheath, I mean. So we can increase the pressure of intravenous irrigation fluid without any increase of intravenous pressure. So do not hesitate to increase the irrigation fluid when you feel the visual field is red.
yeah.
And we can use the monopolar button electrode to coagulate the bleeding focus of the percutaneous trap.
Okay.
We normally call this Buckby device. So we can decrease the bleeding as well. So
Okay.
we can have some tips and tricks to avoid this situation. So maybe we can learn many things from other the experience of other colleagues.
Yeah. My second question to you, Professor Sung, do you think in future, when you are puncturing the kidney, you will be seeing through flexi from where you are coming from to make it more objective, so that no renal artery, no major vessels will be injured? I feel if one of my colleague can keep flexible scope in the calyx, inject contrast and puncture, and he will see where it is coming from, and entire dilatation you watch, make it bloodless, come out safely. Does it?
Yes, very good point. But we cannot see. Yeah, sometimes we can use the ultrasonography with Doppler function, right? But we cannot see the minor vessels, especially the artery is important, so we cannot see them at all. So yeah, if we use the fluoroscopic, just contrast dye, but just we worry about the radiation exposure. So
Yes.
we are stone surgeons. We have to perform the stone surgery forever.
Yes.
But the radiation accumulation of radiation is really worrisome. Yeah, it's a horrible thing. So I don't recommend. So basically, the posterior lower part of the kidney has less vascular structure, but yeah, sometimes we can see. So that's why I started to use the Buckbeam monopolar button electrode to coagulate the bleeding minor vessels.
Will it
And
be effective? Bipolar?
yeah, no, monopolar. Yeah,
Okay.
I want to get a bipolar device as well, but there is no bipolar device in Korea, so I'm just using just monopolar device.
Love to watch. We will love to watch one video maybe in the next session. It's interesting. I was thinking since long time, but I have never tried. I've never tried. Great.
Yeah, sometimes sometimes it works very efficiently, and
When-
just we can see some just if we can check the CT angiography preoperatively, we
Yeah.
can see some distribution of vasculature for the targeted kidney, and we can anticipate some area with less vascular structure. So I try to approach through this area of the kidney, and I try to lessen the bleeding post-operatively. But sometimes I can see some massive bleeding, and I also have some angioembolization cases as well. But it is a very uncommon situation. The complication rate is very low, but just we can see some, we can do some trial and errors to reduce the bleeding risk, and just we can use I already show some examples of CT angiography or the kidney Doppler, or of course some guys are trying to some 3D printing technique, but I'm not sure we have just the good conclusion about this.
Dr. Kwon, I wanted to ask you, when the ureter is tight, when you cannot do flexible ureteroscopy, do you proceed only with the multiple track PCNL, or what is your take on RIRS in tight ureters? In India, we see 30% of the cases we cannot do primary RIRS, 20 to 30%. We don't want to dilate the ureters. We want to put stent and come out and do at a later stage. What is your comment? Because a lot of juniors are listening. 270 audience have joined today. They are listening. So your comment for the juniors, when the ureter is tight, what will you do in your theater?
So in the maybe 1 or 2 weeks ago, I performed such a cases. My junior staff tried to the very tight. You mean that the wrong segment ureter stricture. So he failed to the retrograde surgery. So he passed the patient to me. So I pre-stand for 2 weeks, and then I performed the intrarenal surgery, combined PCNL in that cases.
Good. Yeah. That's a great message. Professor Sung, in South Korea, what is the percentage of PCNLs done by prone versus supine? When this supine has come into significant, like Professor Valdivia sir has made it 1980s when we were in 5th standard. After that, it is not so popularized. And last 10 years, ECIRS, SBS probably is making supine PCNL, inviting again. What is the history in South Korea? What's happening and what happened?
Basically, prone PCNL is the majority.
Yeah.
And the proportion of supine PCNL is increasing.
Yeah.
And actually, we feel that the use of flexible ureteroscopy is increasing, and the technology is evolving very rapidly, and more people are interested in supine thing because they want to use the flexible ureteroscopy more efficiently. Yeah. But actually, the supine is just the supine case is smaller than prone PCNL, and still in Korea. But just young urologists are trying. More and more young urologists in Korea are trying to adopt or perform the supine PCNL recently. So actually, I don't know the exact number of the proportion.
And the last couple of questions. What a flexible scope is, do you think that the flexible scope technology will change in the near future? Smaller size disposable are going to come. What is the current trend in South Korea and in the world with your experience? We are using Boston Scientific LithoView, PUS and Biorad Endovasive reasonably at lower cost with time-bound flexible scope. They are not truly disposable. They are time-bound flexible scopes. And they are all slightly larger, 10 French and above. And what do you think in future? Can we get the flexible scope 6 French or 7 French like that in the future?
We still don't have a very smaller diameter flexible radioscopy. The smallest one is just above 6 French, right?
Yeah.
But the technology is combined with that of other devices such as guide wire, laser, and some other things, catheter. And so we still don't have any such a great narrow flexible ureteroscopy working device. But more important thing is, I think the durability of the flexible ureteroscopy, and just the technology is very important to for us to have a good opportunity to use the very small, narrow working device of flexible ureteroscopy. But I think just we need more time to get such an ideal flexible thing.
The last question for both of you. What do you think the residents, how much time they are taking to learn RIRS surgery? The residents' learning curve for RIRS surgery versus supine PCNL. I feel before I listen to you, I train RIRS, they are getting trained faster than PCNL. So this is the last question. We want to listen from you as teacher, you are senior teachers. So with that, we'll conclude. Last question, please.
Dr. Kwon, do you have any idea about this?
Oh, well, so I also experienced the 10 years prone PNL. So then in that situation, I also some hurdle to change the modified supine position PNL. So, well, I don't know where exactly, but at least the 50 cases of supine PNL, if the surgeon is a beginner, will be necessary for the used to that kind of skill. For intrarenal surgery, I think it's relatively easy. So the surgeon can try to single small stone for using the flexible scope, and then he can advance his cases more complex and complicated. So he can adjust just a couple of maybe 20 or 30 cases of RIRS will be enough for I think.
Great. That's the way RIRS is learning curve is short and picking it up. Professor Sung, any conclusion remarks you wanted to give?
Okay, just regarding the last question. Actually,
yes,
I made a training module of 3D technology. Using 3D technology, I made a module, and actually I trained all of my residents. And when I trained them 10 times per each side, I mean left and right, they became the surgical skill became plateau before 20 cases of flexible ureteroscopy. So I think it is a matter of intensity and opportunity to expose to the surgery procedure. So just I cannot accurately tell the number of what the enough experiences or what the enough cases is, but I think it more and more opportunity, and I just quite agree to the Dr. Kwon's opinion. The 20 or 30 cases intensive educational program can be enough to to our residents, but I think the kind of amnesia or just forgetfulness or the repetitive experiences is more important than the initial intensive educational program. So continuous educational program like this, pure urology, you made this, this continuing educational program is very important, and direct experience should be accompanied together in our places. Anyway, just thank you for this opportunity, and actually I enjoyed this time with my good friend Dr. Kwon and Dr. Chandra as well. So just I think I didn't know the presence of pure urology. Sorry for a long time, but
it's only 7 months now.
Really?
7,000 urologists have joined.
Really? Yeah, just with so many programs and so many webinars you already have. So I was astonished to see the continuous educational program like this and continuous presentation with many well-known, distinguished speakers. So anyway, I really love your active activities with the pure urology, and thank you for this opportunity to us, and maybe many audience will appreciate your efforts for this.
288 audience.
Really?
Fantastic. A lot of audience from Korea also. A lot of audience from international other countries like Spain, Italy. I really appreciate. This is a new part of the stone management. I thank Professor Sung, Yong Cho, and Dr. Kwon. Really appreciate, and you have taken pains nearly an hour or so. It's around 9:30 p.m. in Korea, so it's late dinner time and sleep time. Thank you very much once again. Thank you, audience. Tomorrow we have a great professor talking on how institutions should teach the students right from open surgery to robotic surgery by Dr. Professor Mandal, who is my mentor and who has taught hundreds of students for 4 decades in Postgraduate Institute of Medical Education and Research in Chandigarh. Tomorrow 5 o'clock we'll have the talk. And thank you once again, both the speakers today. With this, we will conclude the session. Thank you very much.
Thank you.
Thanks so much.
Bye-bye.